And we move to the next speaker, and that is Julia Challinor from US, and she will be discussing on role of nurse in pediatric cancer patients management.
So before Julia speaks, may I request Kavita to please keep your question in the chat box, or we can discuss during the panel discussion. In the interest of time, we will not be allowing too many questions presently. We will discuss and we will pull on the panel discussion a little longer. And before Julia starts, let me introduce her that she is very senior pediatric oncology nurse, and she has vast experience of the Indian circumstances also. She had worked in Rajiv Gandhi Cancer Hospital for I think more than 7 years, and I had a meeting with her during the SIOP meeting in Abu Dhabi, and she has hardcore interest for the pediatric oncology, very well experienced, very well trained and experienced with the Indian circumstances. With these few words, Julia, over to you, please.
Good afternoon. My name is Julia Challinor. I'm a pediatric oncology nurse, the Secretary General of the International Society of Pediatric Oncology, and an associate adjunct professor of nursing at the University of California, San Francisco in the US. It's a pleasure to be with you here today to discuss advances in oncology nursing practice and cancer treatment. I've been asked today and tasked with describing the role of the nurse in pediatric cancer management. And I thought I would open with the US-based Association of Pediatric Hematology Oncology Nurses, APHON, 2014 Scope of Pediatric Oncology Nursing Practice Guidelines. The first standard is about assessment and requires that the nurse assesses the child's physical, psychosocial, cultural, and spiritual needs for an appropriate plan of care. Number two is diagnosis. This is nursing diagnosis to identify the problems and determine appropriate interventions, expected outcomes, plans, and evaluation. The third is outcomes identification, to work with the family and child to meet the mutual goals of care. Expected outcomes means adequate education, optimal growth and development, optimal physical and emotional health, minimal symptom distress, prevention of toxicity or chronic complications, and early detection and screening for cancer reoccurrence or second malignancies, which is a serious concern in childhood cancer. Standards 4 is planning, guides the healthcare team to implement evidence-based interventions that facilitate the achievement of expected outcomes. 5 is implementation of nursing action to prevent and treat healthcare problems associated with the diagnosis of cancer or blood disorder. The overall goal is to improve the child's health status, promote quality of life, and facilitate optimal family functioning across the care continuum. 5A is coordination of care in a variety of settings, necessitates communication and coordination among settings to provide quality of care. Health teaching and health promotion provide daily education to promote, maintain, restore, and improve the health and comfort of the child with cancer or a blood disorder, all nursing considerations. I'm not going to discuss standards 5, C, D, and E because these relate to advanced practice nurses, a specific role in the United States. But standard 6 is evaluation of interventions for the patient, ethics related to nursing care, education, for example, nursing continuing education, and 9 is evidence-based practice and research. Standard 10 refers to the quality of nursing practice. 11, again, communication with other members of the healthcare team, patients, and families using strategies to contribute to a positive working environment through responsible professional behavior. 12 is leadership, demonstrates leadership skills, as nurses do, necessary to promote nursing care delivered to children and families, and the profession of pediatric hematology oncology nursing. 13 is collaboration and refers to the coordinated and ongoing interaction between the child and family and the multidisciplinary team. Professional practice evaluation includes self-evaluation as well as peer and supervisory input in accordance with current professional nursing standards. And finally, Standards 15 and 16. 15 is resource utilization. The nurse delivers safe, effective care and utilizes resources efficiently. The nurse's clinical and administrative decisions consider available resources and desired outcomes of care and reflect the ability to prioritize actions and utilize colleagues to achieve desired patient outcomes. And finally, environmental health promotes a practice environment that reduces environmental health risks for patients, families, and clinical and non-clinical staff. Nurses comply with all national, state, regulatory, and specialty practice guidelines. This has given you some idea of the breadth and scope of nursing practice for pediatric oncology nurses across the United States, and I think many apply to nursing of children with cancer and childhood cancer care across the world. I'd say the number one goal for pediatric oncology nurses is to anticipate potential treatment complications. We are dealing with children from newborns all the way through late adolescence, and in some cases, young adults. You need to know your patient's age and stage of development. What are the implications for nursing care and treatment? What are the implications for your interactions with the patient's parents or caregivers? You need to know the medications and treatment the child is receiving during the treatment. What are the potential side effects? What is the nursing care to prevent or reduce those side effects? What do you need to teach the patient about these drugs and treatments? And what do you need to teach the parents and caregivers about these drugs and treatments? This is much to cover. Therefore, I'm going to pick out a couple of highlights, just talking about two drugs, chemotherapies right now, to give examples. So chemotherapy-related complications can include the side effects of, for example, vincristine or vinblastine given by IV, which can include high blood pressure or hypertension, feeling tired, alopecia, myelosuppression, tumor pain, but most importantly for the nurse and most worrisome, I think in general, are neuropathologies as signs of major toxicity. That would include constipation, bone and jaw pain, and foot drop. A second example is of a chemotherapy-related complications are the side effects of methotrexate, a quite common drug we use in pediatric oncology, given by mouth, IV, injection, or into the spinal canal, and can include blood clots or thromboses, pericardial effusion, pericarditis, neurotoxicity, dizziness, tiredness, headache, alopecia, acne, rash, ulcers, itchiness, inflammation of the bowel, enteritis, bleeding, nausea, vomiting, and inflammation of the mouth or mucositis. Here I pause because mucositis, which is extremely distressing to children, especially very young children, and can lead to infection, and the patient will need morphine just to eat in some cases. If mucositis occurs, then the child's entire GI system is affected with negative consequences and requires specific nursing attention. Another high priority is to avoid liver failure and cirrhosis of the liver, and that's why we're monitoring liver enzymes. I won't go through the rest of this complications because you can see them on the right, but methotrexate has a long list of potential complications the nurse must be aware of and vigilant for. Extravasation in pediatrics. I recognize that you've either had or are going to have a talk on extravasation in general by my colleague, Lori Buswell. However, I want to mention in pediatrics what makes extravasation particularly risky. For children, maintaining a peripheral IV or receiving a vincristine push can be at risk of extravasation, for example. Children are active, they're not always cooperative. Their play is quite physical and they're running around and they're waving their arms. This makes it difficult to maintain a patent IV and to even start an IV. So understanding the difference between an irritant and a vesicant is critical. Vesicants can cause permanent damage, severe burns, and even amputations. Drugs that can result in tissue necrosis or formation of blisters when accidentally infused into tissue surrounding a vein are the description of a vesicant. Here I list pediatric oncology chemotherapy that is used commonly and can be, are vesicants and can be of quite high risk for nurses administering these drugs to be vigilant about extravasation, including actinomycin D, dactinomycin, daunorubicin, doxorubicin, epirubicin, idarubicin, mitomycin C, vinblastine, vindicin, vincristin, and vinorelbin. Vigilant nursing care and skills diminish the risk of extravasation for children receiving chemotherapy. Another alternative and good intervention to avoid extravasations is nursing education. I give you an example of a nursing educational intervention study in Turkey, a recent study in 2020 that was published in the Journal of Pediatric Research. The content of the educational intervention included descriptions of pediatric infiltration and extravasation, risk factors and symptoms, medications and fluid lists that have a greater risk for infiltration and extravasation, scales of infiltration and extravasation, and nursing initiations addressing the prevention and management of infiltration and extravasation, special antidotes, and subjects concerning wound care. The preparation was based on current literature, and the subject was given as a lecture. An algorithm was prepared and printed as a poster and posted in the treatment rooms of children's clinics. Before the education program, the knowledge mean score of the nurses was 9.4 plus or minus 3.22, minimum 0, maximum 17. And after the education program, it rose to 12.13 plus or minus 1.58, minimum 8, maximum 16. The increase in knowledge levels stimulated by the educational intervention was statistically significant at p less than 0.001. This was a visual of the results of this intervention. On the left is the knowledge level of the nurses, and you could see pre-intervention and the increase in knowledge post-education. On the right is the extravasation infiltration rates, which you can see on the left pre-education and the significant reduction post-education. I switch now to fever and neutropenia in pediatric hemato-oncology. Kids play even when they are very sick and may not look or behave as if they have a fever. Knowing ahead of time when a patient is at risk of a fever is critical. I present a short case example. Ayushi is 6 years old. She has ALL and is receiving induction therapy. The nurse takes her temperature at night and she has a fever of 38.1. The nurse is 1 hour from leaving his shift and has 7 other patients to finish care for before leaving. He forgets to call the doctor on the night shift to advise him of Ayushi's fever. The day nurse goes to take Ayushi's temperature 2 hours later because she had to receive reports, so she was delayed. By the time the day nurse sees Ayushi, she is in shock and non-responsive and has to be transferred to the ICU. This is a slide to give you an idea how fast a fever can turn into a very critical and serious situation. On the left, you'll see the time in hours in column 1, the organisms per ml in the center column, and clinical manifestations in the right column. So if you start with time 0 and 1 organism per milliliter, there are no clinical manifestations. By the time you get to 6 hours later, there are over 4,000 organisms per ml and the child has a fever. By the time you get to 8 hours later, you have sepsis, 10 is septic shock, and 12 is death. If you look at the triangle on the right, you'll see febrile neutropenia. This is for children who are neutropenic. You start with a bacteremia. 2 hours later, you have septicemia. 2 hours later, septic shock. And 2 hours later, you'll have death. So you really have there a 6-hour window. And this is important for nurses to understand when they take care of children with cancer who are neutropenic. This is an algorithm from my hospital. It's the Pediatric Oncology and Bone Marrow Transplant Patients with Fever Initial Inpatient Management. This is just an example. The goal is to administer first antibiotic dose within 60 minutes for neutropenic and or clinically unstable patients, or in other words, what we often call the golden hour. And this is why we are constantly counseling parents that if that child has a fever, they must come immediately to the hospital. I want to discuss now survivorship, because we all hope when the children are first diagnosed, our goal is and we hope for survivorship. And in fact, National Cancer Survivors Day is on June 6th this year. Children respond better to cancer treatment in general than adults. They are more resilient physiologically. They have less comorbidities, for example, high blood pressure, diabetes. They have less negative lifestyles. They generally do not smoke or drink alcohol. Higher survival rates than adults are generally believed to be related to, among other things, clinical trials, because more children are treated in clinical trials in general than adults. However, survivors of childhood cancer often live many years with secondary sequelae of their treatment and a higher risk of second cancer. They often miss significant schooling during treatment, which makes adult employment and careers challenging. Stigma related to being a cancer survivor, including potential infertility for some diagnoses, can affect marriage, employment opportunities, and adult quality of life. These are important outcomes for pediatric oncology nurses to be aware of, even during treatment and preparing children and families for this after survivorship and during survivorship. Fortunately, in India, there's Kids Can Connect. This is a group, and I've given you the URL. It's a childhood cancer, teenage, and young adult survivor group under the Can Kids, Kids Can group in Delhi. Cancer patient survivors, siblings, peers, and young volunteers can be part of this group. A capacity building platform creating a pool of career-enhanced professionals who have successfully reintegrated back into society make up this group. Survivors turned cancer ambassadors advocating for cancer in their own capacity and career stream are active within Kids Can Connect. Kids Can Connect are currently running a 2-year internship-based fellowship model for survivors, and that may be worth looking into for any of you who are caring for children or adolescents or young adults who've survived childhood cancer. Sometimes there is end-of-life care required, and I'm sorry that the logo here has blocked the title of the slide, but I'm going to discuss here end-of-life care, and this is an e-learning that's free program. The International Children's Palliative Care Network is quite well regarded around the world. It has these programs. The modules include Introduction to Children's Palliative Care, Pain Assessment, Child Development and Play during palliative care, Communication and Emotional Issues, Grief and Bereavement, which I think is very important for us as nurses to be aware of and have the skills for in dealing with families and the patient when cure is no longer possible. Finally, a second resource for you called Together. This was created by St. Jude Children's Research Hospital in the United States. Above the red line are the different links that you can go to about pediatric cancer, diagnosis and treatment, care and support for families, life after cancer, and teens and 20s. I've given you the URL. It's an excellent resource for your making teaching materials to work with family, patients and family education, and also for new nurses who are onboarding. On the right is an example of the landing page. It's so large I couldn't fit it all on the slide, but it will give you an idea of the plethora of information available for you for free. So in summary, a pediatric oncology nurse, aside from being the best kind of oncology nurse, in my personal opinion, because I love pediatrics, is to be a bedside clinician, knowledgeable about childhood cancer disease, treatment, survivorship, and end-of-life care, who delivers appropriate nursing care throughout the child and family's cancer journey. An advocate for patients' families' rights and health within hospitals and governments and the public area. Also, for a productive and a safe work environment to advocate for that in your hospital or clinic or setting. A supervisor and leader who builds trust with the patient and family, provides mentorship to new nurses, and a teacher who educates patients and families, the public, and local, national, regional, and international stakeholders about the challenges, barriers, successes, and benefit of excellent pediatric oncology child treatment. Please keep the nursing light of Florence Nightingale burning for your pediatric patients with cancer and their families, and join me and our colleagues across the world giving care for these super important patients. Thank you.
Thanks, Julia, for nicely presenting the aspects of pediatric cancer patients' care